I'll guide you through every bullet point from your slides, but in a way that feels natural and talky, not robotic. Let's start. Section 1. Understanding eye anatomy. Okay, so before we jump into diseases, surgeries, emergencies, we need to actually understand the parts of the eye, but we're not doing this in boring textbook language. I want you to picture the eye. Let's walk through it together. The sclera. This is the white part of the eye, the tough outer coat. Now pause for a second and ask yourself, why would I ever care about the color of someone's sclera? Because the sclera is a window into the whole body. If it's yellow, think liver disease. If it's bluish, think connective tissue disorders. If it's red, think irritation, infection, allergy. This little detail tells you a lot. The cornea. That perfectly clear dome over the iris. The cornea is like the windshield of the eye. It bends light. It must stay smooth and clear. Now ask yourself, why is the cornea so sensitive? Why does even a tiny scratch feel awful? Because it has tons of nerve endings, more than almost any other body part. That's why corneal abrasions bring people into the ER crying. The lens. The lens is the structure that focuses light so we can see things sharply. Young lenses flex easily. Older lenses stiffen. That's why older adults hold their phone farther and farther away. The lens can't flex the same way. If the lens becomes cloudy, cataract. We'll talk about that in a bit. The retina. Now the retina, this is the film in the camera. It's where light turns into electrical signals. Damage here? Vision loss is immediate and permanent in many cases. If the retina detaches, that's an emergency. The optic nerve. Think of this like the cable connecting your camera to your computer. If it gets damaged, blindness. That's what glaucoma does. It slowly squeezes this nerve to death. Case example, anatomy in real life. A patient says, "It's like a curtain came down over part of my eye." What structure might be involved? The retina, likely a retinal detachment. Another patient says, "My vision is cloudy like looking through wax paper." That's the lens, likely a cataract. Anatomy becomes your diagnostic superpower. Section 2. Eye assessment. Let's walk through how you examine eyes, but let's do it realistically. Visual acuity, the Snellen chart. This is our baseline. 20/20ths doesn't mean perfect, it means normal. 20/100ths means what? Think about it. The patient needs to be 20 feet away to see what a normal person can see at 100 feet. Translation, serious vision impairment. Now ask yourself, why is it important to test vision before giving any eye drops or starting any treatment? Because you need a baseline to tell whether things are improving or worsening. Peripheral vision, confrontation test. We stand in front of the patient and wiggle fingers in each quadrant. If they don't see fingers coming from the side, think glaucoma. Earliest sign is peripheral loss. Eye movement, the H test. We're checking cranial nerves 3, 4, and 6 if the eye can't move in a certain direction. Why would that matter? Because limited movement can indicate nerve damage, stroke, brain pressure, or trauma. Pupils, perla. We check. Size, equality, reaction, accommodation, unequal pupils, stroke, head trauma, brain herniation. Always pay attention to pupils. Case example, the motorcycle crash. Patient comes in after trauma. One pupil is blown, the other is normal. This isn't an eye problem, it's a brain problem. Increased intracranial pressure is compressing the oculomotor nerve. This is an emergency. Section 3, cataracts. Okay, now let's talk cataracts. Think about the lens turning cloudy, slowly, gradually. Symptoms, cloudy vision, glare at night, blurry, hazy vision, colors look faded, frequent glasses changes. Here's a question. Why do cataracts cause glare and halos at night? Because the cloudy lens scatters incoming light, especially headlights. Risk factors: age, diabetes, steroid use, smoking, UV exposure, treatment, surgery. And modern cataract surgery is quick, often 15 minutes. The cloudy lens is removed and replaced with an artificial one. Case example: I can't see to drive at night anymore. A patient says headlights look like explosions or starbursts, classic cataracts. Section 4. Glaucoma. Glaucoma is one of the most dangerous eye diseases because it is silent. There are two main types. Let's talk about them. Open-angle glaucoma, most common, very slow, painless, targets peripheral vision first. Patients don't notice it until the damage is already significant. Angle closure glaucoma. Sudden pain, red eye, halos, nausea, vomiting, decreased vision. If not treated, permanent blindness in hours. Now let me ask you something. Why does glaucoma damage vision? What's actually happening inside the eye? Because fluid doesn't drain properly, pressure increases, optic nerve gets crushed over time. Once nerve fibers die, they don't come back. Case example: bumping into door frames. A patient reports hitting the edges of doorways repeatedly. What should you suspect? Peripheral vision loss, likely glaucoma. Section 5. Macular degeneration. The macula controls sharp, central vision, the part you use to read, see faces, or drive. Two types: dry, wet. Symptoms: central blind spot. Straight lines look wavy, faded colors, loss of detail. Here's a thinking moment. Why is macular degeneration emotionally devastating for patients? Because losing central vision takes away independence, reading, driving, recognizing people. Case example: I can see the edges, but not the words. They can see the margins of a page, but not the center. You should be thinking macular degeneration. Section 6. Retinal detachment. Okay, this one is a true eye emergency. The retina pulls away from its blood supply. Cells start dying immediately. Symptoms: flashes of light, floaters, curtain coming down, sudden loss of vision. Why the urgency? Because the retina dies without oxygen within hours, and once it dies, vision is permanently lost. Case example: the top half of my vision is gone. That's retinal detachment until proven otherwise. The nurses move? Get the patient lying still. Call the provider immediately. This is surgical. Section 7. Diabetic retinopathy. Diabetes destroys the tiny vessels in the retina. Symptoms: floaters, blurred vision, dark spots, poor night vision. Why does diabetes destroy vision? Because sugar damages the microvasculature, and the retina is full of tiny, delicate vessels. Case example: my vision gets worse when my sugar is high. Yep. Retinopathy is strongly tied to glucose control. Section 8. Eye trauma. Let's talk trauma quickly but thoroughly. Foreign bodies. Do not rub the eye. Do not attempt to remove embedded objects. Flush chemical exposures for 15 minutes. Penetrating injury. Stabilize object. Cover both eyes. Do not remove it. Corneal abrasion. Very painful. Feels like sand in the eye. Case example: the guy using a weed trimmer. Metal fragment flies into the eye. He tries to remove it with tweezers. Nope. Do not remove it. Cover both eyes and transport immediately. Section 9. Common eye medications. Let's talk meds in a conversational way. For glaucoma: beta blockers, prostaglandin analogues, carbonic anhydrase inhibitors, cholinergic agents. Pilocarpine constricts the pupil. So teach patients about dim light vision problems. For infection: antibiotic drops. Do not touch dropper tip to eye. For inflammation, steroids. Case example. Everything seems dim. A patient on pilocarpine says rooms seem darker. That's expected. The pupil stays constricted. Part 1 closing. All right. That's the full, super in-depth, conversational, interactive lecture for eyes and vision, rewritten with clinical instructor energy and podcast smoothness.